As you may have noticed, there are a lot of situations in the preceding notes that use the prefix schizo, which historically has been very confusing for people. This fact's going to try to remedy that. You can think about some of these terms as if they were on a spectrum, even though they aren't actually on a spectrum, but it's a way of conceptualizing the differences. For example, schizoid is a simple personality disorder where people act eccentric and tend to withdraw socially, whereas schizotypal is a more advanced form of schizoid because people are not only eccentric, but they also tend to have bizarre and odd thoughts. Schizophrenic patients are on a level above that because they have even more odd thinking, along with the other clinical criteria that we discussed earlier, and it tends to be more pervasive, limiting their function. Schizoaffective can be thought of as a step above schizophrenia, not because it's necessarily worse, but because it adds yet another element, that is, a mood disorder, to schizophrenic symptoms. The mood disorder can be either bipolar or depression. Also remember that we discussed the disease schizophreniform disorder, which is basically schizophrenia whose symptoms have lasted less than 6 months. So let's put you to the test here. A 20-year-old man is seen by a physician for the 3rd time in 3 months. The first visit he was brought to the emergency department by his mother after swallowing toilet bowl cleaner. He told the doctor that he took the cleaning products to cleanse his body from the aliens that had forced their entry and possessed him. Today the patient appears unclean and disheveled, and his mother reports that he is becoming progressively withdrawn and expressionless. 4 months ago the patient witnessed the gruesome death of his father in a drive-by shooting incident. Prior to this incident he had a normal and healthy life. What's the most likely diagnosis? It's most likely schizophreniform disorder. He meets criteria for schizophrenia with delusions and social withdrawal, but it's been going on for less than 6 months. Always, always, always pay attention to the time frame in order to avoid losing easy points. The next set of disorders are often mischaracterized in the popular media, and it's important to know the true definitions of these terms. The 2 main diseases that we discuss are anorexia nervosa and bulimia nervosa. Anorexia nervosa is characterized by excessive dieting with or without purging. Often these patients will also have an intense fear of gaining weight. To qualify as having anorexia, these patients must have a body weight less than 85% below the ideal body weight. They must also refuse to gain weight greater than 85% of their ideal body weight. The DSM criteria also require patients to have had 3 missed menstrual periods consecutively if the patient is a woman. Anorexia nervosa is associated with decreased bone density, metatarsal stress fractures, amenorrhea, anemia, depression, and severely altered electrolytes. In fact, what would be the most likely electrolyte problem in these patients? Hypokalemia from extreme dieting and possibly from purging. Bulimia nervosa is characterized by binge eating with or without purging. These patients will often self-induce vomiting following meals or use laxatives or diuretics. One distinguishing feature of bulimia nervosa versus anorexia nervosa is that bulimia nervosa patients often maintain normal body weights. However, this disease is associated with parotitis, enamel erosion from repeated vomiting, electrolyte disturbances like hypokalemia and hypochloremia, and particularly alkalosis. So what's the type of alkalosis and why? It's metabolic alkalosis secondary to GI loss of acid and contraction alkalosis from hypovolemia. As seen here, these patients may also show Russell sign, which refers to dorsal hand calluses that occur from repeated attempts at induced vomiting. Gender identity disorder is characterized by persistent discomfort with one's gender, causing significant distress and a persistent cross-gender identification. Some terms to be familiar with include transsexualism, where people have a desire to live as the opposite sex, often through surgery or hormone therapy, and transvestism, which describes wearing clothes of the opposite sex. You can keep it straight by remembering transvestism involves clothing only, and the term contains the word vest, which is obviously a type of clothing. The following 2 terms, substance dependence and substance abuse, are similar and therefore at times difficult to distinguish. Substance dependence refers to a maladaptive pattern of substance use defined by 3 or more of the following over the course of 1 year or more. Tolerance, defined as needing more of the drug to gain the same effect. Withdrawal, defined as experiencing symptoms following cessation of the drug. Taking the substance in larger amounts or longer time than desired. A persistent desire to quit. Significant energy spent on obtaining and using the substance. Important daily activities reduced because of substance use, or continued use in spite of knowing the problems it causes. Substance abuse is a maladaptive pattern leading to clinically significant impairment or distress, but not meeting the criteria for substance dependence. Impairment and distress can manifest in many ways, primarily recurrent use despite difficulties legally and at work, school, or home, as well as putting individuals in hazardous situations. This fact is a fairly words-relevant fact and offers a good way to conceptualize the counseling process for patients suffering from drug abuse. It's also great for tracking your progress when you realize caffeine has come to have too strong a grip on your life. The first phase is called pre-contemplation, wherein people are not yet acknowledging a problem and are truly not interested in quitting their substance. Historically, most attempts to do drug abuse counseling have failed in patients who are still in the pre-contemplation stage. The next stage is contemplation, where patients will acknowledge a problem exists, but are not yet ready or willing to make changes. The third step is preparation to make a change, and fourth is actual action, in which behavioral changes are embraced. The fifth step tends to be a difficult one as well, that is maintenance, wherein people have to maintain their newly developed behavioral changes. Of course, when patients are unable to maintain their new behaviors, they may relapse into their old behaviors. This is not to say an intervention is unsuccessful. It's common for patients to go through these stages multiple times before patients can effectively maintain their new behaviors. This is a very high-yield topic for the boards, and one that can be very difficult to get straight. Remember, it's important to remember the key signs and symptoms you see from an abuse of a drug, and oftentimes the opposite of those effects will show up when withdrawing from that drug. Generally speaking, when people abuse depressants, classically alcohol, they'll have nonspecific symptoms like sedation, behavioral disinhibition, and mood elevation. Withdrawal often presents with nonspecific symptoms like anxiety, tremors, seizures, and insomnia, which makes sense as these represent the opposite of a depressant's effects. The first example is probably the most boards and wards relevant. Abuse of alcohol leads to emotionality, slurred speech, ataxia, coma, and blackouts. Accordingly, withdrawal effects are similar to the ones mentioned earlier, i.e., anxiety, tremors, seizures, etc. However, with severe alcohol withdrawal, patients can develop delirium tremens, which we'll discuss in greater detail in a moment. When you think about treatments for drug abuse and withdrawal, remember this basic fact. Drug abuse is treated with antagonists. This is because the problem is that patients are experiencing drug toxicities, and an antagonist will diminish the effect of the drug at its receptor site. In contrast, withdrawal occurs because the body is in need of the drug to work at its receptor site. Therefore, withdrawal is often treated with agonists. Additionally, pay close attention to specific treatments if they're described. For example, flumenazole, a GABA antagonist, is the treatment for benzodiazepine abuse and is a classic board scenario. As you work your way through the list, you should pay particular attention to distinguishing traits. You'll notice many aspects of depressant and stimulant abuse and withdrawal will overlap. Therefore, you should remember these effects, but don't count on them as being helpful to determine which specific drug toxicity a patient is presenting with. Look for the distinguishing features of drugs. For example, there's only one drug on the list that will classically present with angina, cocaine, as it's a potent vasoconstrictor. Another easy thing to keep in mind is what happens to pupils. Particularly, you'll note that two stimulants, amphetamines and cocaine, have pupillary dilation as part of their diagnosis, but opiate abuse leads to pupillary constriction. Remember, though, that opiate withdrawal will lead to pupillary dilation. Keeping these things straight may initially take some time, but it's important to find these distinguishing characteristics and use them in a way you can easily remember. The three hallucinogens that are classically discussed are PCP, LSD, and marijuana. PCP is commonly tested because it is known to cause very aggressive behavior among abusers. The other signs of PCP intoxication are more nonspecific, but a clinical scenario of a patient caught in some sort of illegal situation, i.e. assault, should trigger the thought of PCP. As a fun side fact, Baltimore and New Haven, Connecticut hold the dubious honors of having the highest rates of PCP abuse in the country. LSD is known to cause flashbacks in its abusers and should be a similar sort of pathognomonic indicator. Otherwise, its symptomology is often nonspecific. Heroin abuse is a super boards relevant topic. It's important to know that the use of injection drugs will predispose patients to a wide variety of ailments. The more obvious ones include AIDS and hepatitis. The trickier ones that can be pathognomonic include right-sided endocarditis. The treatments are also very boards relevant. Long-term control for patients with history of opiate addiction was classically achieved with methadone. Other newer options include Suboxone, which includes a partial opiate agonist called buprenorphine, as well as naloxone, an opiate antagonist. The naloxone portion is not active when taken orally, so withdrawal would only occur if someone tried to inject the drug, with the hopes of getting intravenous buprenorphine instead of oral. This is quite clever when you think about it. Combining these two drugs reduces abuse potential, but also tends to decrease withdrawal symptoms. In the context of clinical vignettes, as previously mentioned, be suspicious of opiate use in patients with pinpoint pupils. Alcoholism is a much more boards-friendly topic than the marathon you just went through. The reason is because there are very classic disease entities that occur with alcohol abuse, with nutritional deficiencies associated with alcohol abuse, and also alcohol withdrawal. It also tends to be far more commonly seen in the hospital in real life. As an entity, alcoholism is defined as a physiologic tolerance and dependence that is associated with symptoms of withdrawal when it's not consumed regularly. The complications are very varied, from hepatitis to pancreatitis, as well as cirrhosis and all of its associated stigmata. One of the main clinical entities associated with alcoholism is Wernicke-Korsakoff syndrome, which is associated with thiamine deficiency. As you may know, the syndrome has two separate triads in it. The first is Wernicke's encephalopathy, confusion, ophthalmoplegia, and ataxia. If it continues, Wernicke's may progress to Korsakoff psychosis, which is characterized by irreversible memory loss, confabulation, and personality change. Pathologically, this is associated with periventricular hemorrhage and a more pathognomonic finding of necrosis of the mammillary bodies. This is something you ought to be able to recognize on a CT scan. It can be treated by IV thiamine, aka vitamin B1, which only really works if it's caught during the earlier stages of Wernicke's encephalopathy. If the disease has progressed to Korsakoff's, it may not be reversible. Administration of a large dose of glucose in the setting of subclinical thiamine deficiency can precipitate Wernicke's encephalopathy, so glucose should always be given with thiamine in the setting of potential thiamine deficiency. Why is this the case? Well, thiamine serves as a cofactor in glucose metabolism, so if a large amount of glucose is introduced, the thiamine will be further depleted to increase glucose metabolism. Another disease associated with alcoholism is Mallory-Weiss syndrome. It occurs because patients suffering from alcoholism often vomit profusely, which causes longitudinal superficial lacerations in their gastroesophageal junction. The lacerations often cause bloody vomit, or hematemesis. In contrast to cirrhotics who present with variceal bleeds, hematemesis is associated with pain and resolves spontaneously, often with no intervention, while variceal bleeding will require endoscopic treatment along with pharmacological therapy. To treat patients with alcoholism, often the most productive way of maintaining abstinence is with support groups like Alcoholics Anonymous. That said, there are also medications that can help. Disulfiram is one example. How does it work? It inhibits the action of acetaldehyde dehydrogenase, causing acetaldehyde, a toxic byproduct, to build up and make patients feel awful, thereby conditioning patients to not want to drink. As you can imagine, though, it's often quite difficult to maintain compliance with medication like this. While disulfiram is not a very boards-relevant medication, you might remember some drugs have a disulfiram-like reaction. Can you remember a few? The answer is on page 272 and includes metronidazole, some cephalosporins, and first-generation sulfonylureas. Delirium tremens, or DTs, are another important clinical entity to be familiar with that are associated with alcoholism. It is a consequence of alcohol withdrawal that is potentially life-threatening. The risk of DTs peaks 2 to 5 days after the last drink. The initial symptoms show autonomic system hyperactivity, including tachycardia, tremors, and anxiety. Next, patients will exhibit psychotic symptoms, including hallucinations, delusions, and confusion. Incidentally, it's also the name of a famous Belgian pale ale that won multiple awards for its quality. Do you remember what kind of hallucinations patients with alcohol withdrawal, suffering from DTs or otherwise, will experience? That's right, tactile hallucinations such as formication or the feeling of ants crawling under your skin. The main treatment for DTs is usually benzodiazepines. Additionally, it's important to give alcoholics acutely abstaining from alcohol benzodiazepines prophylactically to prevent DTs.